Yes, absolutely. We should get started. Welcome to always one of my favorite rounds of the year, QI rounds. Many thanks to Dr. Wendy Hatch, Stephanie Lowe, and Jonathan Michelli. Those latter two have taken the torch from Dr. Nancy Epstein, who also has helped to lead this for us for many years. I see she's with us this morning. I think we have some great topics today. One of them is definitely of interest to me because it just happened to me yesterday. I had a last-minute surgery cancellation just yesterday in the OR, in a bilateral case to boot. So I'll be interested to see what I can do to prevent that. Also, we're going to talk on where have all the IA patients gone and reducing orbital wait times for periocular oncology. So I think these are fantastic topics, and I very much look forward to today's rounds. And so I guess the slides are up and we're ready to start.
Sounds good. So my team is up first. I'm Lily. I'm one of the PGY5s in the Department of Ophthalmology. And along with my co-residents Amrit Rai and Yellen Yang, under the supervision of Dr. Stephanie Lowe, our QI project is about where are my patients, KEI OR cancellations. And of course, a special thanks to Dr. Hatch and Dr. Michelli for their help. So throughout today's rounds, we're going to put up a couple of poll questions. I know there's some QI gurus out there already, but for our juniors and people who are just starting, we're going to go through the entire QI process and demonstrate the steps with our own QI project. So here are some questions to keep in mind. Number one, which of the following are not going to be one of the domains of quality improvement? 2, what does PDSA stand for? 3, what is the other term for an Ishikawa diagram? 4, what rule does the Pareto analysis use? And what do S and T stand for in the SMART aim statement? So this is an overview of all the steps in the QI, and again, we'll demonstrate everything with our QI project. So just an anecdote to start. It's the big day. It's been a year, a hell of a year, waiting for everything to happen. Your mom's sitting at home waiting for you to pick her up, sipping her coffee, enjoying her croissant. You've taken the entire day off work to bring her all the way down to Toronto at Kensington Eye Institute. You fight traffic all the way down the DVP, and you finally arrive at the surgical center. And the first thing they ask is, did your mom eat or drink anything today? And of course, as surgeons, we've had this all the time where patients violate their MPO and we have to cancel them. So when you're identifying a quality problem, the 3 things you should ask yourself is 1, is it important and clinically relevant? 2, is it common? And 3, is it feasible? And generally speaking, they'll fall under one of the 6 domains. So the 6 domains of quality improvement are the following. 1, patient safety. So of course, do no harm to the patient. 2, timely care. And it's especially important in COVID, but the idea is to reduce waste and prevent harmful delays. 3 is patient-centered care, so putting patient values at the center of our clinical decisions. 4 is efficient care, so how do you minimize waste and maximize our resources? 5 is effective care, so how do you provide service to those who need it, but not to those who don't benefit? And 6, and last but not least, is equitable care, so care that does not vary due to personal characteristics. So for example, how do we ensure that people in Northern Ontario are able to get the same degree of care as we do in Toronto, for example? So our particular project looked at Kensington OR cancellations. And we know that Kensington performs over 10,000 cataracts a year, and last-minute cancellations cause unfilled spots and leads to wasted resources. And it's especially difficult because any spots that could have been filled now go into a wait list. So the 2 domains that we address are efficient care and timely care. Once you identified a problem, you need to confirm that the problem does exist, so you would do a gap analysis. So in our gap analysis, we looked at the cancellation rate between 2017 to 2019 within 48 hours of surgery. And the reason we chose 48 hours is because it's very difficult to find a new person to replace somebody with 2 days, heads up. The cancellation rate was 67%, and that was a total of 679 cases over 2 years, which works out to be about 33 full OR days if you had 20 patients each day. And the top 5 reasons for cancellations were as below. So number 1 was no explanation given. Number 2 was the patient's canceled. Number 3 was MPO status. Number 4 was patient was ill. And number 5 is the office canceled. So no explanation given was actually the most common reason, which wasn't really acceptable to us. So between November of 2019 to February of 2020, we prospectively called patients who had that as their listed reason. And our preliminary analysis actually showed the most common reason was still MPO status and patient illness. So we considered an intervention targeted towards the most preventable reason for cancellation, which was MPO status. So once you have a problem and you've confirmed that it exists with the gap analysis, the next step is to engage and identify your stakeholders. And these are people who are going to be influenced by your QI project. Generally speaking, they fall under one of four categories. So the champions, the helpers, the bystanders, and the resistors. It's particularly important to identify the champions and the resistors because the champions are the people who are going to help push your QI project through. And the resistors often have legitimate concerns that you do have to address and win them over to your side. So when we looked at our stakeholders, obviously the patients and surgeons are top of our list, but also Kensington Eye Institute and the various offices that the patients have been booked out of were also stakeholders that we had to engage. So rather than a hypothesis for a QI project, you actually prepare an aim statement, which specifically lays out what you're trying to accomplish. And usually we use a SMART format. So SMART stands for S, specific, M, measurable, A, applicable, R, realistic, and T, timely. And so our particular aim statement was to decrease the number of patients canceling surgery last minute due to MPO violations by 50% by March of 2021. And now I'm going to hand it over to Yellen.
Okay, so once you have a QI question, now we need to determine the causes so that we can refine our specific interventions. And there's a couple ways to do this. So through a fishbone diagram, Pareto analysis, or a process map. So the first is a fishbone or Ishikawa diagram, and this helps to visualize and categorize the different potential causes of a quality problem. Typically, they're divided into broad categories.
Yellen, I don't think we can hear you. Are you on mute?
We might be having some technical difficulties with Yellen's internet connection. Maybe we can have
Yeah, I can step.
That's okay. One of our colleagues step up. Yeah, thank you.
Yeah, no problem.
Thank you, Lily.
So anyways, we're talking about fishbone diagrams. And so you can broadly categorize it as patient and provider factors, organizational characteristics, and equipment. So let me just get onto our slide. Okay, so when we were looking at it, these are some patient and surgeon factors that we listed. So that included patients being sick or family being sick, forgetting about the OR, changing their minds, booking surgery elsewhere, a lot of different surgeon factors. And then we also looked at the day of surgery issues and clerical issues. And specifically, the one that was very easily targeted and should be 0% is MPO status not being maintained. And so that's what we decided to focus on. There's also the Pareto analysis, which helps identify the most important causes. And it's based on the Pareto principle, which is the 80-20 rule. And it says that 20% of possible causes determine 80% of our outcomes. So for example, when we're looking at it, MPO status violations is 106 out of 679 cancellations. And so that's about 15% of cancellations. And so that's something that's very easily targeted and will have a big impact if we can get it to 0. And the last thing we can use is process mapping, which is useful in projects that are evaluating efficiency. And so if you map out all the steps of your current process, you can help identify bottlenecks, responsibilities of the different groups, and variations in practice, and then steps where efficiencies can take place. So this is a process map of how we get our patients from from consultation to all the way to surgery. And specifically, this is where we wanted to intervene. Patients are reminded of their surgery date by phone or by letter about 3 to 4 days before their surgery. And then they usually don't get reminded on the day of surgery about the MPO status.
Thanks, Lily. So once the problem is identified, minor changes can be implemented and tested on a small scale using a PDSA cycle. Unlike research studies that require large sample sizes and often a single intervention, the PDSA cycle allows new learning to be built into the next cycle in an iterative fashion. Multiple cycles are often needed to achieve the desired change. So first you plan your change, then you implement the change, then you collect information on the outcome of that change, and finally you refine the idea based on the information that was gathered. Next slide.
Sorry.
For our study, we recognize that patients are given a surgical package that contains preoperative and postoperative information and recommendations. Part of this package is an eye drop calendar that patients need to review on a daily basis starting 3 days before their scheduled OR date. we felt that this would be an ideal place to add a reminder to stop eating after midnight the night before surgery. So we plan to add the reminder, provide the updated calendar to all patients, and collect the rate of cancellations due to NPO violations. And then just as we were about to start our first PDSA cycle, COVID struck, and the ORs were shut down for an indeterminate amount of time. This is an example of the post-op drop calendar handout that is given to all patients before their surgery. It allows them to cross off drops that they've instilled so they don't lose track of how many drops are needed per day. This is a calendar that patients will be looking at multiple times per day, even before their surgery. And so in the third box on the first row and in large font in the top right corner of the handout, we included a reminder to not eat anything after midnight the night before their surgery. Next slide. After our first PDSA cycle, we analyzed the results from 60 patients and found that there were no cancellations due to NPO. While this was a good outcome, the sample size is small, and so we decided to proceed with our second PDSA cycle. For our second PDSA cycle, we set up an automated text message to go out the evening before surgery to remind patients to not eat anything after midnight the night before their surgery. In order to implement this intervention, we needed to ensure that patients had their cell phone numbers registered with the EMR. And again, we collected the rate of cancellations from NPO violations. Next slide. In order to send out the automated text message, we used a texting service called ClinicoNext that integrates with multiple EMR systems, including Oscar, to send out text message reminders around 8 p.m. the night before surgery. Here you can see an example of a text message that was sent out. The text message reminds the patient to not eat anything after midnight that night and to not eat anything the following day until after their surgery is complete. Next slide. We are currently collecting data from this second PDSA cycle. It is important to recognize that with QI projects and PDSA cycles, the interventions are iterative and are built on top of each other. So far in this second cycle, we've had one cancellation due to NPO. Unfortunately, our study was halted due to the OR shutdowns and slowdowns, but after we analyzed the results of our current PDSA cycle, we plan to consider additional interventions, such as sending out another text message the morning of surgery. And since the text messages are automated, this wouldn't require any additional work from our administrative staff. Additionally, because the ClinicoNext system is now integrated into the Oscar EMR, we can expand this intervention easily to other KVRC-based surgeons. Thank you. We're happy to take questions.
So as we do that, I think we've got a couple poll questions for the audience. I'm just going to launch the first one here. So we're going to see if people are paying attention. All right, I'm going to end this one quickly because it's pretty overwhelming. So there you go, Wendy. There's your result there. And I'm just going to share the second one. I hope people get this one too. It's not PDA.
This is a trick question. Yeah, it was a trick question. Sorry, it was a trick question. I actually Googled PDSA and came up with all three of those top ones.
Okay, so here's the third one. People are awake this morning, Wendy.
Excellent. Wow, 100%.
So there was a question from Alan Berger here. I don't know if Alan just wants to share it with the audience.
Oh no, I just said that I was told not long ago that our orthopedic department actually has a cancellation fee. I have no idea whether that's something that the ministry allows, approves. I guess if they give them lots of notice and they claim it's for extra administrative work and stuff, but they've been doing it, and they've been basically telling their patients if they cancel within 48 hours without a good reason, without a medical reason or some other valid reason, they can be charged $200. I have no idea what number is the magic number, dollar amount, but you know, somewhere along the line, it may not be a bad idea just in terms of a disincentive. I don't know how often they collect, especially with the St. Mike's population. But you know, it's an interesting thought, considering that it's not just the surgeons who are, the whole system, like the whole healthcare system, it is ripped off when that happens for no good reason. So, and I don't know, but I'm sure many of the private surgical centers have something like that. I don't know if any of you operate at private surgical centers and can comment.
Well, you know, even at Kensington, we do in theory have a late cancellation fee, but it's not enforced. So I don't know if we've ever actually collected. It's mostly just to be a disincentive.
Well, if you don't cancel it, anyway, no, I mean, the word probably isn't out that it's a veiled threat, but I wonder whether it's something that could be considered. John or Al, do you guys work at all, like maybe for, I mean, not for cataract surgery or for refractive surgeries or anything like that?
I'm not working at a refractive center, Al, so I can't comment. But you know, I used to do pterygiums in the hospital. We now do it in the minor treatment room. And if somebody had something to eat, we don't cancel the surgery. We just, you know, in fact, we don't even tell them to be NPO. So it really begs the question, do we really, I mean, how many times are we going to go from a local anesthetic to a general anesthetic with cataract surgery? So it begs that question. The other thing is, you know, there's more and more of a move by the ministry to go to not having anesthetist or anesthetist assistants involved with cataract surgery. So we will probably be monitoring these patients. I think the next QI study may be looking at, you know, how important is this to be NPO? And I'm just wondering, some of the private, you know, refractive centers are doing cases later on in the day, 6, 7 o'clock or whatever. Are patients being asked to fast that whole time, or just the 6 hours before their operation? My question is, how important is fasting after midnight for a local anesthetic that I don't think in the last 20 years I've had somebody who had to be switched to general.
Yeah, I think those are really valid comments, Alan, and actually Marko Popovic and Matt Schlenker are looking at that question right now. If you look at the guidelines actually for local and topical, they really should be able to drink until 2 hours before their surgery, and Marco's starting to explore that, and then we'll look at eating as well. I think those are very valid. And you know, Alan, you're absolutely right that disincentive is really important. And the interesting thing is that as we get wait lists shorter, people tend to cancel more frequently, knowing that they can easily rebook in a reasonable amount of time. And so we do need multiple strategies, and I think one is a disincentive, but I think this type of project shows that some easy steps can make a difference as well. That's really important. Thank you.
So we should probably move on to the next one, Amity.
Okay, I can get started. So my name's Sam Meinecker, and I'm working with Mohammed and Brian, and our supervisor is Dr. John Michelli. And the title of our talk is Where Have All My Patients Gone? IAH Patients Lost to Follow-Up. And Brian won't be joining us today because he had a very welcome addition to his family yesterday and is very, very tired right now, but we can welcome Scotty McKay to the program. So many patients are referred for IAH to a neuro-ophthalmology practice, although it may be something that's seen more rare in a general ophthalmology setting. And anecdotally, there's a high number of no-shows for these patients. And this may be due to it being a young demographic that has not lost vision, and otherwise they're feeling relatively well. But if these patients are untreated for a long period of time, we know they can present later with irreversible vision loss. And so we chose to assess this abnormal number of no-shows at Dr. Michelli's KEI clinic because the EMR was very easy to access there. We performed a gap analysis to see if this was even an issue. And so we looked at the last 60 patients, and he had a 2/3 attendance rate. So about a third of patients with IAH were no-showing to their follow-up. So this was an issue that we thought was worthy of addressing. When you think of the stakeholders, similar to the last problem, we have physicians, their time, their scheduling, the patients, that are waiting in line that want to attend their appointment, as well as the patients themselves who may be unaware of what may be happening to their vision down the road. There's obviously the clinic and resource management and other patients as well as taxpayers who contribute to our healthcare system. And so our aim was to reduce the rate of no-shows by 50% over a 3-month period at KEI in his clinic. And our aim then would be to have a roughly 80% attendance rate. And so I'm gonna now let Mohammed describe our Fishbone diagram.
Thanks, Sam. So this is our Fishbone in this project. And so multiple factors have been identified as contributing to the high rate of no-shows in IIH patients, starting with the clinic factors like no follow-up given or the long wait times, especially for a patient who is relatively asymptomatic and aware of how serious the problem can go down the road. That might be a limiting factor for patients to stick to their follow-up appointments. Rescheduling issues or misunderstanding about follow-up. Patient factors, as we said, like misunderstanding the severity of disease or denial. Other health and family issues preventing patients from attending their follow-up appointments. Healthcare system factors, I think this is also an important one, secondary referral to another specialist. We know that IIH patients often get referred initially to multiple services, maybe 2-3 services. So they could probably lose like in the middle of these services, or they might choose to just stick to like the neurologist, for example, missing all the care necessary by the ophthalmologist. Some patients might prefer to follow with their optometrist or they are inpatients elsewhere. Other factors like transportation issues, geographic or weather issues preventing these patients from coming to their follow. Advance them. So here are our QI domains of focus in this project. As you will see later, like patients will be called and information were gathered from them. So and whatever implementation was done was actually based on the patient's preferences and whatever they felt that it will make a difference for their next follow-up appointments. By ensuring timely follow-up, we are trying to optimize the patient safety and this disease that could potentially result in irreversible damage to the optic nerve, and of course, timely care. Advance them. So the initial analysis involved like calling 20 patients from the no-shows, and although like few were reached, but the most common comments that we've heard is basically patients saying like, "Oh, I felt fine. I didn't feel that I need to come back for the follow-up," or patient wasn't aware of any appointment. So appointment reminder strategy was discussed, given all the options: phone, text, email. And patient was given the choice to choose like among the 3, and most of them have chosen text in addition to the usual routine phone reminders. Also based on the discussion of the patient, a new handout was made to be given to the patient at the time of their appointments. And the handout is in the next slide. This is a picture of the handout. It's just explaining to the patient just a few lines about IIH, how serious the disease could be, and the potential for irreversible damage with totally asymptomatic patient. And so the next step was to basically start collecting data after the implementation of these changes. Advance them. So this started on November 2019. So we started to go week by week and looking at IIH patients who attended and the number of no-shows. You want to go ahead, Sam?
Yes, I'll take over from here. And so we collected our weekly data week by week, and we didn't foresee that there would be a global pandemic starting in March. And so we looked at our rates sort of pre-COVID, and we nearly hit that 80% attendance rate. And surprisingly, when we look at sort of the entire duration of the intervention from November till September, including COVID, we actually had a good attendance rate of 87%. Our initial rate was 2/3 and our goal was above 80. And so we were quite surprised by this. And it may be due that this is a younger patient that was less fearful of the implications of going outside and attending their appointments at that time. This is a run chart, and it's something that's used in these quality improvement projects. And the thing to note is that if you have 6 spots above sort of our goal line, it means that it was a successful intervention, and you can see we have much more than that. And so if you look at when our intervention started, and then if you follow it, and then you follow it well beyond COVID, it continues to be very high. The reason there are a few blips here, and that's why we showed you some of our raw numbers, is that some of these weeks there may have only been 1 or 2 patients, and so if 2 of those patients don't attend, then the numbers will have a dip like this. But overall, we can see a clear trend that this intervention was very successful. And this is just that sort of same information, but in a pie chart format as well. And so, in summary, this is a real issue, and about 1/3 of patients we saw were no-showing to their appointments. A very simple intervention, giving them a handout, sort of outlining this condition, that it's a relatively asymptomatic condition, the severity of potential vision loss from it, and really showing them a picture of what that nerve looks like in their eye seemed to be helpful, additionally to giving patients reminders about their appointment, and really choosing a method to remind them that was most helpful to them, and that being text for most of these patients. We implemented this intervention from November to September, and all these patients received the handout as well as the reminders. Just to summarize, the initial rate was 67%. Our goal was to increase it to 80%, and we were able to exceed our goal. Future directions, it may be to see if this improvement rate can be further improved, and to see if after COVID, there may be some COVID-specific barriers, and this number may be even higher. Additionally, there are similarities to other conditions where you have young patients that are very vulnerable to permanent vision loss. And you can see this sometimes in diabetic retinopathy, some uveitis patients that are waiting to start a disease-modifying therapy or steroid-sparing agents and are maybe hesitant to do that, in addition to younger patients with glaucoma. And so that may be good areas to see if some of these similar interventions may have an impact as well, but gap analysis will need to be performed prior to that to see if it's useful. And we'd like to thank you for your attention.
Thanks, guys. Myrna, did you have some comments you wanted to make?
Yeah, sure. Well, I deal with a very vulnerable population, but I have to tell you there are other patient factors that will not be addressed through your questionnaire. And there are a few simple entrance questions that I think may be helpful in identifying other barriers to care. I would include age, education, especially, and income. So that if you are dealing with a poor person who is on limited means or who does not speak English, your questionnaire will not engage them. And these questions do not have to pose a big risk or a big demand on your administrative staff. These can be included in your income assessment. Simply asking their age, where they live, their income, and whether they speak English may actually capture some of the no-shows, especially in other vulnerable populations. In fact, in our homeless population, where I engage the patient at intake, we only have a 58% show for our consults, slightly higher among women for a number of reasons that I can discuss at another talk. But 58% of my homeless patients, after I engage them and tell them they have to see somebody for their retina because of diabetes, show up for their appointments. And we have to have a different strategy to deal with patients who may not have the ability to read your request, to understand what you're saying to them, or the ability to actually show up to their appointments. That's my comment.
Yeah, those are all good points, and certainly, and this project was kind of started because we had a patient go to the emergency room who had a very severe vision loss and needed an urgent shunt. And when we went back in the chart, this patient had missed a number of appointments. So after we kind of did our gap analysis, I agree with you. There's many factors, and I certainly make a point to try to address these when I see the patient. I agree with you. Many of these patients are young women. Many have new families. They can't really take time to go to appointments. So I do try to, get a feel for the patient to see how we can help them. Sometimes patients come from a far distance, so we alternate appointments with a local optometrist or ophthalmologist. So those are all good points you raise, and I certainly do try to
I know you do.
figure out what type of factors are at play.
Thank you.
And Mandeep, do we maybe I want to put up the rest of the questions, the full questions?
So I'll put up the rest here. So everyone is certainly getting this one.
Great, 96%.
And let's go to our last one.
Great.
Okay, so Yusuf, do you want to go ahead with your presentation?
Yeah, for sure. Let me just share my screen. All right, so hi everyone. My name is Yusuf Ahmed. I'm a medical student here at the University of Toronto in my third year, and I'm happy to be providing an update on our interesting QI project titled Improving Periorbital Oncology Wait Times here at the Mount Sinai Hospital. And I'd just like to extend some thanks to Dr. Hatch, Dr. Lowe, Dr. Michelli for running this session and also getting the opportunity to present here. I'd like to also thank the University of Toronto Department of Vision Sciences, the QI grant, which allowed us to complete this project and has allowed us to do some exciting things. So I'll get started with a case. So starting with the case of Mr. B, who is an 87-year-old gentleman who worked for 45 years as a power line technician. And in November of last year in 2020, his son noticed a small rash in his right temporal area while on FaceTime with him. Unfortunately, due to COVID, his son wasn't able to see Mr. B until early December when he took the photo you see here. He tried to book an appointment with a dermatologist, but the appointment only took place a couple months later because of the spike in winter COVID cases. He was eventually seen in early January where these new pictures are taken. And as you can see, the lesion has progressed up to the point where it's highly invasive, and he was diagnosed with an invasive squamous cell carcinoma that had rapidly progressed in the last 2 months. So this patient, Mr. B, is likely destined for an exenteration procedure. And you can see that delays in care for eyelid cancer patients can be the difference really between losing an eye and keeping it. And it can be the difference between a simple direct closure that takes 20 to 30 minutes and the patient's back to normal in a few days versus a 1.5 hour procedure that requires a skin graft for the eye to be sutured shut for 4 to 6 weeks and a second surgery. So this is only just one example of how delays in treatment can really impact the quality of care of our patients. With cases like Mr. B in mind, Health Quality Ontario, which is an advisor for provincial healthcare, developed the Ontario Wait Time Strategy in 2004. And with this wait time strategy, specific cancer wait time benchmarks were created to improve patient quality of care. These wait times were specified as wait 1 and wait 2, and wait 1 was defined as the time from the referral from the primary care physician to the ophthalmologist, and wait 2 was defined as the time from the decision to have surgery to the actual surgery taking place. And for these lid cancers, Health Quality Ontario recommends wait 1 to be less than 35 days, and for wait 2 to be less than 85 days. So, analyzing the wait time compliance at Mount Sinai compared to our provincial averages, we performed a gap analysis that showed that there was some clear lagging behind for HQO compliance at Sinai compared to the other Ontario hospitals. And you can see that specifically wait 1 was behind. It was only 31% compliant as opposed to the 72% of the other hospitals in the province. So our group sought out to improve wait times for the periorbital oncology cases at Sinai here, and specifically for our aim statement, it was to achieve greater than 80% compliance with the provincial targets for wait 1 and wait 2 by June 2021, and we were going to do this through the implementation of quality improvement PDSA cycles. The first step we did was we engaged our stakeholders. We identified our stakeholders who had some vested interest or role in providing care to our population of lid cancer patients. And these stakeholders were identified and determined to be the referring physician, the oculoplastic staff physician, administrators in the hospital and clinic, and also the surgical coordinator. And of course, the patient who also has a role in their own health as well and is at the center here of this diagram. Key stakeholders were then interviewed to provide insight into the referral pathway of our patients that outlines the patient flow of care. So as you can see, typically patients are referred to the oculoplastic staff by a primary care provider. The oculoplastic staff then triages the referrals, and sometimes the administrators actually do this triaging as well. And this all is done based on level of urgency. The patients then seen in the clinic by the oculoplastic staff, and an OR is booked if that is decided, if it's determined to be cancerous, and then the surgery would then take place. So that referral pathway allowed us to generate a fishbone diagram to brainstorm ideas that could possibly be contributing to these wait time increases that we see. And patient factors such as patient delays, cancellations, poor health literacy, poor quality referral information on the side of referring physician factors, admin staff factors like scheduling patterns, and also staff ophthalmologist factors such as awareness of the HQO benchmarks, their OR availability, were all identified as contributors to the increased wait times that we see. For our first PDSA cycle, we decided to target the staff ophthalmologists, the administrative staff factors to reduce the periorbital oncology wait times. So we knew that from our interviews with the administrative staff and the staff ophthalmologists that specific referrals are generally seen in a time frame that I've outlined here on the slide. And we came to understand that for 2 of our staff ophthalmologists, lid cancers were triaged and generally seen within 4 to 6 weeks, which is still typically above that 35-day threshold for wait 1. And then for another ophthalmologist, Dr. C, referrals were all triaged, and they were triaged by the administrative staff, who then booked them for 2 to 3 months unless specified as urgent. So another gap there. Seeing that the majority of these cases and the wait times is greater than 35 days, we decided to try and improve the compliance with HQO benchmarks through several strategies. So we engaged the stakeholders by hosting meetings with the staff ophthalmologists and the administrative staff, where we reviewed the Health Quality Ontario guidelines, why it was important to follow them, presenting similarly cases such as Mr. B. And then we also placed posters throughout the clinic, throughout the office, actually physically saying and stating the HQO benchmarks to provide that visual reinforcement. And the whole idea of this low-hanging fruit idea was to first educate and then propagate the message of seeing our lid cancer patients in a timely manner. So did this work? So for our first PDSA cycle, we compared our pre-intervention audit health quality compliance to the post-intervention. And as you can see, wait time 2 was actually much better. It was 94%. However, despite the education to the staff ophthalmologists, the posters, and also to the administrative staff, wait 1 still lagged behind provincial averages and was still below our 80% threshold that we aimed to sought out for our aim statement. So we went back to the drawing board, looked back at our fishbone diagram, and we aimed to identify another potential area that we could improve wait times. And for this, we decided to focus our next efforts on the referring physician factors, so like referral quality information. We were specifically interested in how referral quality impacted the wait time benchmark compliance. And we're also wondering whether referral information could potentially be optimized to better allow the ophthalmologist to complete triaging in a more accurate and efficient manner. So to do this, before we could propose another intervention, we first needed to identify what exactly could be optimized in the referral side of the equation. And to do this, all referrals to the oculoplastic clinic at Sinai during the period of our last PDSA cycle were identified, and referrals for cancer, for suspected cancer, for ambiguous referrals, so a lesion NYD, and referrals under a benign etiology, such as a chalazion that ended up being a cancer, were retrospectively reviewed and analyzed. We looked at key outcomes like the wait times, the consultation and biopsy diagnosis, and the referral sensitivity and specificity for identifying eyelid cancers. So this is a QI project, and typically in QI, these strategies aren't necessarily done, but we did review 969 charts, and we did this so that we could potentially add value to our project and determine and identify what exactly we could optimize in the referral side of things. So from those charts, 113 patient charts and referrals met inclusion criteria and were analyzed. 14 of those were for cancer referrals, 34 for suspected cancer, 58 were for ambiguous lesions, and 7 were for benign etiologies that ended up having cancer retrospectively. For the overall cohort, 36 cases had biopsy-proven cancer when were treated with excision and reconstruction. And the main takeaway from that initial analysis and background was a large proportion of patients were determined to have cancer in oculoplastic assessment, but were referred as a benign lesion or as a lesion not yet determined. And this is really important because when the staff ophthalmologists are triaging referrals, they need to be able to identify patients that need expedited appointments. So appointments within 35 days to meet that Health Quality Ontario benchmark. And this is all done through the referral information, the quality of information that they get. Earlier, I showed you the Health Quality Ontario compliance for Wait 1 and Wait 2 following our first PDSA cycle. And following the referral analysis that we performed, we hypothesized that the false negative referrals and the ambiguous referrals may be making it difficult for the staff ophthalmologists to exclude or to accurately triage patients effectively. So if we look at the same population from our last PDSA cycle, but exclude the patients not referred explicitly for cancer, so excluding those false negative cases, you can see that Wait 1 jumps all the way up to 85%. So we think we found our answer as to how we could possibly optimize the referrals in the future to decrease wait times. We tried to understand why exactly this was taking place. And as I alluded to before, this may be because physicians may not want to commit to exact diagnosis on paper when they're referring to an ophthalmologist. And this key data trend outlined that they were somehow able to eliminate false negative referrals and non-specific referrals, our cancer patients can get the expedited care that they deserve and they need. So how did we exactly decide to address this problem? So for our next PDSA cycle, we came to understand that our team shifted focus towards enriching the actual referral information to avoid missing those false negative referrals and cancers that were responsible for the inflated wait times that we saw. And one of the ideas was that we came across in the dermatology literature is that photo referrals have become increasingly popular in dermatology, and they show great diagnostic accuracy. They've been shown to decrease wait times, and they've been shown to decrease morbidity and mortality in cases. Not to also mention the economic viability of e-consults and photo referrals, reducing face-to-face interaction and more. The whole idea was that if we could enrich the patient referrals, to enrich referral information, we could prevent those false negative referrals from falling through the cracks. So how did we do this? We decided to collaborate with the Ontario Health Telenetwork and the eConsult Ontario to set up a virtual consult and referral platform. And the stepwise progression would be the patient would see their primary care physician in the clinic as they normally would. And the referring physician could then take a picture of their lesion, send it to the oculoplastic staff through an e-referral on OTN. The oculoplastic staff will provide an e-consult and triage the patient for a visit when necessary. So if they deem that based on the picture information and the referral text information, it's possibly a cancer, they'd book them within that 35-day time frame. And then, as I mentioned to you before, another reason this was appealing was because during the times of COVID, we're always trying to reduce face-to-face interaction And this is one way to do so and still provide care to our patients. Reducing cases like Mr. B, where they go 2 months without being seen and their lesion has progressed up to the point where they may require a surgery that has a higher morbidity. So where are we currently at right now? So we actually will be launching our OTN e-consult service today. So we'll be sending out messages on OnTi and also to our referral sending a fax blast. So this is a nice timely presentation. In 3 months' time, we'll be reanalyzing the wait time trends to see if our quality improvement interventions actually made a difference and driven down those numbers. And we look forward to seeing if it's actually made a difference. So that's where we're currently at right now. We look forward to seeing if our QI intervention is making a difference. And thank you for your time. Welcome any questions.
Yusuf, that's a great presentation and very effective. That's wonderful. You know, to ensure that the photo referral works well, the technology has to be relatively straightforward to get buy-in. Can you tell us a little bit more about the ease of uploading, say, a photo from your smartphone to the OTN referral?
Yeah, so the OTN referrals can actually be done on the tablet as well, and OTN is still optimizing their software to try and get it on the phone as well. But the idea would be, so the patient would come to the clinic, the ophthalmologist or referring physician would take a picture of the actual lesion. They could upload it to OTN on their phone, and then they can fill out the consult on their computer if they're actually doing that there. So there is, some barriers that we recognize may occur, or at least take place, and we hope to have an ongoing dialogue with the referring physician to try and optimize this new e-consult service, this new e-referral service, because there will be a little bit of a speed bump we anticipate, but I think being in constant communication with our referring sources, referring a database, will hopefully be able to mitigate those speed bumps.
Could I also ask, it's always interesting to hear about the time limits with regards to wait times. You mentioned that the wait one limit is 35 days. Do you know how that was arrived at?
Yes, that's a great question. These things are, they have to be evidence-based. And one of the reasons why we think that patients weren't being seen within the 35-day timeframe was because maybe it's not even necessary to see them within the 35-day timeframe. A lot of the times, these guidelines are based on maybe not necessarily specific lid cancer lesions, but based off of dermatology literature and BCCs. And in clinical practice and clinical expertise of the oculoplastic ophthalmologist, a lot of the times that the patients weren't being seen within that 35-day timeframe, it may not have made that big of a difference. But there are, of course, outliers like Mr. B, where patients come in and they're not being seen in 2 to 3 months. And that's where we get in trouble, is by extending those wait times way beyond the 35 days. So I think another really interesting next step would be to go back in literature, go back and review the lid cancer patients and see, is that 35-day metric really what we should be targeting? I think maybe we don't have that answer yet, but that is what Health Quality Ontario recommends to us. But nonetheless, something that we hope to at least see if it's really necessary or different, and we need to change that in the future.
Yusuf, as a corollary to that question, these numbers seem remarkably specific, like the why 35 versus 30 versus 40. And the other thing I always find interesting is that once they set these benchmarks, we then use a percentage of patients that reach that target. But if you had only 2% of patients reaching the target, but because the mean was 37 days, that's a very different scenario than a terrible percentage where the mean is 70 days. And I've always wondered about these studies where they set a target and then percent that meet it. It almost seems like it's artificially created to, maybe they chose 35 because it could get a high percent meeting it. Anyway, I'm just curious, when you did the projects, if you thought about looking at the actual number of days instead of the percentage hitting a target.
Yeah, definitely. That's a great question. So we actually looked at both the mean wait times and then the HQO compliance in terms of reaching a specific threshold of patients that met that 35-day timeframe. And the reason in this presentation and relevant to quality improvement research, we reported the compliance percentage was because that's really the wait time metric, or I guess that's the metric that we're targeting, the guidelines that have been given to us. But the great point that you bring up is, let's say a patient seen in 34 days, they meet the guidelines by just 1 day. But if a patient's seen in 100 days, they're no different than a patient seen in 36 days, which is essentially almost the same as a patient who's seen in 34 days. And from what I remember from our analysis, the mean was, I think it was roughly, mid 40s. So it wasn't terribly off the 35-day time frame. Nonetheless, we didn't really reach that threshold of 35 days, at least even half the time. So going back to the question Dr. Elderfrawi brought up about what is the relevance of that 35-day time frame, can it be extended? Is it really doing that much of a difference, making that much of a difference in decreasing morbidity and mortality? That's maybe where looking at mean wait times are of interest, and going back and reevaluating whether these guidelines should be changed.
Yusuf's doing such a great job answering these questions, and I'm stuck with a mask because fellowship doesn't really lend well to sneaking away from the OR for this stuff. But the HQO guidelines are for eye cancer, and those were created for more specifically with working groups for things like uveal melanoma. And there currently are not guidelines for dermatologic cancers from HQO, although those are in the works and would likely be much more relevant to our project. And then for benchmarks, their goals are to make sure the most people possible in the population can be seen within whatever time they determine. So things like averages, like Yusuf said, are skewed by outliers, whereas benchmarks more accurately reflect what's happening to the average or to the majority of Ontarians, for example.
Those are great comments, Jeremy. Thanks. It's funny. Same with cataracts, and Wendy will remember this. When we struck the cataract wait times, it was basically an expert committee that decided there's really no evidence to go on, and so it was. We were told by the ministry that we needed 4 priorities, come up with times, and that was what the group decided. And then as time went on, we had directives from the politicians saying, well, we need more patients in priority 3. So change your guidelines to ensure that these wait times change according to the needs of the government. So it's always interesting weighing the evidence versus the reasons that we make change.
Yeah, I remember being on the panel and then seeing these guidelines, benchmarks, and went, oh, is that what we decided? So it is interesting how it all comes about. So great presentations. Jeremy, I believe this was your PGY4 project in the beginning, wasn't it?
So yeah, it was myself and Rebecca and Sarah, yeah.
So thank you for continuing to make improvements and passing the baton to Yusuf, and great job on keeping it going. And also thank you to being able to provide funding for it as well, which has been great. So that's thanks to Alan. So I think that's probably the end of today's session. And I just want to say that during past year, I think it's impressive that we've been able to continue to improve efficiency and safety and access to care during these difficult times. So I congratulate you all on wonderful projects, and thank you, Stephanie and Jonathan and Jeremy, for leading these projects.
Yes, thanks everyone. Always very, very entertaining rounds every time. Wonderful. And as a final question, since I do get cataract cancellations, this text-based interface that you use, how much does it cost, or does it cost at all? And can it be used with, non-EMR practices, other interfaces? Curious about that.
I'm not exactly clear on the cost of the program, but it does if you go to the ClinicalNext website, it lists a bunch of different EMR systems. So it's not restricted to only Oscar. It has a lot of the common ones. I think Akuro's on there as well. I'm fairly confident that even without an EMR, they could set it up because it's all on a back-end server where everything's happening. So I'm fairly certain that they would be able to do it in a, in a clinic that doesn't have an EMR.
All right, once again, don't forget to fill out the evaluation form. Amandeep has put it up in the chat. And have a great weekend, everyone.
Thank you.